So let us then begin. And the first issue, I think, has been referenced a number of times, as well as in the questionnaire that we sent out to you. And I think I'd encourage many of you to look at the questionnaire in advance that we sent out. And we've got a pretty good response rate, at least for health professionals. It's about 70%. And what you'll see is that it's a kind of a pre-vote Iowa caucus view of many of these topics. But as has mentioned several times, the first question is a question of nature versus nurture. I think all of us understand that part of the social accountability of health professional educations is to place our providers in rural and underserved communities. And that's really tough no matter where you are in the world. And in order to do that, the question has been framed, is it better to recruit the right people in, or is it better to frame and emphasize those specific competencies that will help them practice in that setting? So the specific proposal that I'd like your vote on is health professions, educational institutions should place more emphasis on admissions than in training specific competencies during the educational program. If you are in favor of that, raise your folder. All right, precinct captains. All right. All right. So then the second one, if you did, okay. So the first one, do you want to revote, Patricia? So here's the proposition. What I want you to say, are you for or against? The first question is for. Health profession, educational institutions should place more emphasis on admissions than in training specific competency during the educational program. You'll get a chance. You will want to vote on both sides of most of these questions, but all right. Who's in favor of an emphasis on admissions? Boy, then. All right. All right. Do we have all the votes? Then who wants to put our emphasis on all right. Who would want to put priority on training specific competencies? Okay, hold them up while we're counting those votes. Okay. All right. So nature versus nurture. I'm going to ask Rick Kellerman and Sarita Verma to take both sides of this, at least initially. So, Rick.
Well, about 10 years ago, Jim Collins published this book, Good to Great, Why Some Companies Make the Leap and Others Don't. And what Collins said was that there are certain companies that get the right people on the bus. That is the primary thing that he says in this book. And he says that if you get the right people on the bus and you put people together and you let them talk about things and you give them a task, they'll do the right thing and your company will succeed. And if you don't get the right people on the bus, it doesn't matter what direction you're going, you're not going to get there anyway. He also said that these companies look for specific attributes of applicants when they're applying to the workforce. For example, they look for background. They look for educational attainment. They look at work ethic. They look at things like, can this person work as part of a team? Are they committed? And here's my question to you. Why would we think that it's any different in choosing applicants for health professional education programs? Now, we have some evidence that shows that if you choose the right people, if you get the right people on the bus, they'll do the right thing. For example, rural applicants, for example. If you want people to go to a rural area, pick applicants from rural areas. Now, we can have rural curricula, we can have rural rotations, we can have scholarship programs, but if you don't have an applicant that comes from a rural area, they're not going to go to a rural area to practice, or they're not going to stick in the rural area. If you want people to work in diverse communities, get a student body that is diverse. If you want people who are going to go into primary care, choose people who profess that they want to practice in primary care. And we know that people that go into primary care are more likely to come from lower socioeconomic groups. If you want to predict who's going to do well academically, look at MCAT scores in medical school or look at GPAs. Now, MCAT scores and GPAs are really important because we don't want to admit people to health professional education that don't have the intellectual capacity to get through the rigorous curriculum. But it's a little bit of a problem with MCATs and with GPAs because they're numerical. You can rank them from top to bottom, you make a cutoff point, and you may not even interview individuals who have the characteristics that you want in your health professional program. So the AAMC has a admissions initiative, and they've identified 9 core competencies of what at least medical schools should look for in their applicants. And let me just read those 9 and see if it resonates with you. Reliability, service orientation, social skills, capacity for improvement, resilience, cultural competence, oral communication skill, teamwork, and ethical responsibility to self and others. And so if you agree, in conclusion, I want you to vote when you're on the admissions committee to get the right people on the bus. And I want you to vote with your cards when Sarita and I are all done. Thank you very much.
On the con side will be Dr. Verma.
Do you want me to come up there?
It's your choice.
You
Sure.
do? To me, it looks like I only have to keep 3 people on my side. Well, I can see the numbers. So thank you, Rick, because you actually made the case for me. The admissions criteria that you identified are actually the admissions criteria that we need to have on place in order to effectively train people and to scope them and sculpt them towards the multiple areas of practice that we want them to go into. So we're not just trying to get people through our health professions education to go into one particular area. We're looking for a broad base of individuals coming into health professions who are capable and competent to go to any area. And that's what your admissions criteria identify. Are they actually able to go from informative to formative to transformative learning, which was what the basis of the Lancet Commission spoke to? Are they able to actually traverse a science-based education to a disease-based education to a systems-based education? Again, those characteristics will predispose those people to be in environments where they will be able to acquire the knowledge, skill, and attitude to go to rural or underserved areas, to practice in a quaternary care setting in critical care, or to practice in a community-based community health center in a longitudinal integrated setting. From the University of Toronto, we train, we're the most research-intensive university in Canada, ranked #1 in Canada and arguably in the top 10 of the world. But we produce 40% of the family doctors for the province of Ontario and 25% of the family doctors for the country. It is possible that a child is born with the potential ability to learn Chinese or Swahili, to play the violin, to climb a tree, to make strudel, or a birdhouse, or to take pleasure in finding the star system. Genes and inherited characteristics may determine the foundation of the house, but time and place and environment determine the form of the house. So in the case of nature versus nurture, in the case of education, and most of these studies have actually been done outside of medical education, that the duration, the exposure, the repeated exposure, the continuity of exposure, the positivity of the exposure, and the role modeling actually lead to the enhanced opportunities for people to want to practice in areas where there is need. Absolutely. They must have those characteristics beyond intellectual prowess, but their desire to be socially accountable, I agree. But are they going to do that if they only learn in places where they see only a particular way of doing things? No. They must have that repeated boluses of experience, and therefore, anyone who is so inclined to do so will be able to practice in those community-based settings. I will wrap with this final notion, which is that there is no predictability. We all actually probably know, and this will be not very popular, that once we tweak the admissions criteria, we see the luxury cruise liner tweak towards it. So in fact, we encourage people to prepare towards it, perhaps to tell us what they think we want them to hear, maybe even to fudge the truth a little bit. Yes, I want to be a primary care practitioner in this place because that will get me admitted. So there's no evidence to show that the admissions leads to the ultimate practice, but there is excellent evidence to show that repeated continuity, duration of experience leads to practice in those areas. Thank you very much.
Open it up to questions and comments from the group. Yes, Tricia.
Warren, is this the appropriate place to make the comment we discussed? Okay. One of the points that I wanted to make, and I think is just, it's sort of somewhere in between the two, perhaps, but what's happening in our systems is that we have, to a large extent, people who have the right heart and the right spirit coming in, and somehow we beat it out of them. And so I think that it's really looking at what it is we're doing in the training. I've seen that in my profession and other professions where people are making the grade, they're doing everything, but they're not fitting the culture mold, because the culture mold says it's all about just the clinical and not about the personal. And so that social connection, the caring, what we are saying we're valuing here is actually extinguished. The fire in the belly is extinguished, or the fire in the heart. So I think it does come down, I'd have to say training, but I think we need to look at the toxicity of our training.
Good. Nice comment. Yes, John.
My idea is that fundamentally the one and the other are important, but the most important thing is the way you organize your healthcare system. If you have a healthcare system where a family physician earns 8 times less than a cardiac surgeon, in some countries it's 15 times less, then all the good ideas that you bring either in the admission or during the training will be overruled by the incentives. So fundamentally, the drivers of the healthcare system are essential to determine what the final outcome will be. And you see lots of processes of unlearning. Students in the first years, they are really motivated, they are patient-centered. And then they come into the clerkships. And if you are not in highly specialized hospitals, and if you are not if you not integrate sufficient reflection, critical reflection, mentoring, during that process, you see that they take over the implicit curriculum and the hidden curriculum of your healthcare system. And you see then that they unlearn all the things that you have learned them. So if you want to have good outcomes, it will be essential that you put the drivers at the right place. And income is one, ownership is also important. Bureaucratic systems are not as suitable as complex adaptive systems where you have more autonomy. So all these drivers will finally determine to what will be the outcome of your system.
So a payment eats admissions and training for lunch. Yes.
Well, obviously, I wouldn't want to choose between the two, but I think if we look at the most people that are in, let's take medical schools, for example, around the world, they tend to be from a very small group of economic and social background. So if you have criteria, which they're throughout the world is mostly based on academic standards, you don't have a level playing field, and you actually lose the richness and the learning and the culture that can be brought from other communities. And so I think unless you start looking for admission criteria that look at the whole perspective, it's what you need to do in order to provide best care for all, you need to change the admission criteria. Obviously, you have to do both, but I think unless that's done, we're going to sit with the same broken system that was talked about before.
Good. Dr. Skoslak and then Carol.
So, Dr. Verma, I would be more persuaded by your argument if we had the kind of training programs that would produce the results that we want. But at this point in time, the kinds of experiences that students are having, in addition to being a narrow group of students that tend to be selected, have had the outcome of producing the kinds of practitioners that aren't in the best interest of our system. So I would agree with you, but only in the ideal. I think in the real, I'm still persuaded that admissions remains very important.
Carol.
Earlier this week at the Ottawa conference, one of the plenary speakers talked about the implicit curriculum, namely that many of the learners play our academic games according to their desired outcomes, not ours. And I think the persistence of geographic maldistribution, despite 40 years of efforts, it bears witness to this, so I vote for admissions.
Good. Somebody over. Don't scratch your hair. I might think you're calling on. Yes, ma'am.
So I think one cannot be done without the other. It changes in admissions versus training. So, some of you have alluded to that already. But my major concern is erosion of excellence. We talk about changing the training programs and then, changing standards for admissions. My real concern is when a little kid is in trouble, when, sophisticated diagnostic, treatment planning, surgical bioengineering skills are required, we cannot afford to have social accountability alone at the cost of erosion of excellence. So, that remains a major concern. And I think for that not to occur, that erosion, both these need to change, meet somewhere in the middle, not one or the other.
Good. Yes, Marika and then Jan. You can rebut each other, I think. But
Okay.
Marika first.
Let me go before Jan.
Oh, and Carol, did I?
We have changed our admission criteria in South Africa to allow for a broader representative sample of students. But when they come out on the other side, it doesn't matter where they come from or what color they are the same. So if there's not something happening in the program like that lady over there said, then it doesn't make a difference if you change your admission criteria, because if you put them on the same conveyor belt, they will come out the same, whether they came in differently in there. So I vote for Sarita.
I think we're close to the end. Carol, did you have a comment? Or okay, Jan.
I would like to comment on the idea that there is an opposition between social accountability and technical excellence on the other hand. I think we have excellent examples of very high-skilled people that had really a view of social accountability, that were committed to the needs of those that were really most in need. And there's no opposition between both of them. Another opposition that, in my opinion, is false is that for primary care, you don't need the best of the students in terms of performance. I think the diagnostic clinical performance of your primary care physician should be the best, because they have to make the difficult decisions, and it's not either or, it's complementarity. So I really cannot agree with this kind of opposition that there is no evidence to underpin that. And I think if we start from that kind of perspective, we risk during our process to stimulate the wrong kind of reflections and reactions and attitudes.
Good.
So let's be careful about that.
Some great comments. Let us revote the proposition.
Can Rick and I say quick rebuttals?
I'm sorry.
No?
You'll get your, I'm going to ask you after the revote. Okay? So the proposition is that we should place more emphasis on admissions than in training specific competencies. All in favor of that proposition, raise your, is more on admissions than in training specific competencies. More on admission. Hold it up so that we can get the votes. Yeah. Okay. And then all who want to put more emphasis, if you will, on training moving forward. Good. A little bit of a shift, actually, I think, but we'll see what the numbers are. So now's the opportunity for Rick and Sarita to say, what do you really think?
Well, I mean, first of all, we both agreed that, in fact, integrative thinking around this required us to look at both. And someone mentioned, and Bjorn, maybe it was you that really, or I think Patricia, you mentioned, if we don't address the hidden curriculum and if we don't actually deal with what the underpinnings are, what occurs in the socialization as people go through whatever program they go through, we will have a product that will come out that is either distorted or doesn't meet our needs. I just say two things. One is beware of the increasing burden on the prospect that we solve all our problems through admissions. Admissions is not the panacea, and I have this visualization of a young student entering a system who must know basic science, clinical science, determinants of health, be socially responsible, be a good community, and this increasing Lego house on their head, when in fact it's not going to solve the systems issues that we face. And so there's a complex answer to this. However, I will accept the proposition that you cannot teach fish to climb trees, but you can teach bears to dance, and you can send a chimpanzee into space. So we are capable of learning and training and learning complex tasks, regardless of what our admissions are.
Ditto. It's both. I mean, it's, I really think, at least at our school, our admissions, admissions committee does a pretty good job at looking at these things. Yet at the same time, on the first day of the clerkship, I look at some of these people and the things they say, and I go, how did we ever let you into this school? And then you see at the end product also sometimes, and kind of what Pat said, and the hidden curriculum, it is just toxic. We just sometimes, and it, I still see idealism at the end of the second year. That third year, it's just like we beat it out of them somehow, and they become enculturated in this toxic environment. So, but we still have to select the right students, do the best job we can to train them, and then cross our fingers and hope that they'll go to areas of need, for example.
And I'm going to vote on yours.
So thank you both, Sarita and Rick. Yeah. And our experience over time is that it's the rare debate that changes minds, by the way. So let us move to the next debate, which is as we go forward.